longer. Je crois que c'est bon. Donc, on est sur YouTube. So, I would like to thank everybody for enrolled for our HPB Day. It's a great pleasure for us. In the first semester, we had the HPB 22, a course is dedicated for HPB surgery and the HPB knowledge. And so we missed the course, and then we said, why not a second one, quick one, in the second semester just before the HPB 23. So we thought about so, and we talked about that with Professor Allard, which is one of the most important authorities on the field from Brousse Hospital in Paris, France, a place that we have the pleasure to have visited as well. So this is the HPB Day, an online discussion, and it counts with the support of Angelina Caron Hospital, Brazil, which is the hospital where we run transplantation service since 2000. We invited for the discussions of the lecture Dr. Marcelo ENNE, who is a Brazilian HPB surgeon that works at the Hospital Federal de Ipanema, Rio de Janeiro. Welcome here, Dr. Marcelo ENNE. Finally, we have the pleasure to have you here.
Yes, we are together now. Thank you so much for the invitation, for the nice invitation to be here with our friends, Marc, Antoine, and Rafael. Thank you, João.
Thank you. And next, I would like to introduce you all, Dr. Rafael Araújo, oncological surgeon, also former resident in Paris, and who also performed a very outstanding work on especially on robotic surgery, DPCs, and all sort of huge digestive oncological surgeries. Welcome here, and finally, we have your presence as well.
Thank you so much for the kind invitation and the words. It's a pleasure to be here among friends, and thank you. I really appreciate it.
Thank you. And last but not least, Professor Allard, who works at Brousse Hospital, which is probably, if not the most important HPB service in the world, certainly the most important service in Europe, and where we had the pleasure to be there and to know the last updates in these fields normally comes from Brousse. And so the lecture that we invited Professor Allard to present us tonight is about the last updates on colorectal liver metastases. How do we manage this disease in this year of 2022? With all the advances and the possibility of transplantation in some cases. So welcome, Professor Allard. Finally, to have you here as well. Thank you very much for your presence and availability.
Thank you very much for this very kind word and your very kind invitation. It's a great honor for me and a great pleasure for me to share this talk. So the objective tonight is to give you a bit an overview about last update in the management of colorectal liver met. Okay. So I will start by the basics, what we learned at school. I mean, what we learned, maybe 20 years ago. At that time, we all learned that all metastatic colorectal cancer are more or less the same disease, that only R0 resection can cure the patient, and that prognosis is just a question of size and number, referring to the numerous scoring system. But since then, things have changed a lot. Things have changed from a surgical point of view. with many advances in terms of technique, approach, feasibility of resection, and at the same time, a huge advance have been done in terms of the medical oncology, with a better knowledge of the cancer itself, the development of new drug, new association. So I will, and of course, this has been translated in a major improvement of median survival in metastatic colorectal cancer that could not be operated. So it's impossible, I think, to not speak even for surgeon or for the surgical community, to not speak about the molecular biology of colorectal cancer. I'm not an expert, so I decided to select a few points that seems for me important to be underlined. The first thing is to say that metastatic colorectal cancer is no more a single disease. It's actually a very heterogeneous disease. You can see here from the first consensus of molecular subtypes of colorectal cancer, 4 types have been identified according to a different mutation profile and the different infiltration of immune cells, expressions of some genes or some factors, and you can see that it's quite relevant in terms of clinics, even if things have changed more recently. But the message here is to say that it's no more just a single disease. One word about BRAF mutated patient, it's about less than 10% of patients. It's a bad mutation. The V600E is associated with a poor prognosis. And of course, this poor outcome is translated in the few patients that can be operated. Most of them will relapse, and with aggressive relapse that cannot be treated by a repeat hepatectomy. So unfortunately, in this kind of subset of patients, we cannot expect a great result from surgery, even if BRAF mutation should not be considered itself as a contraindication for liver resection. Another point is that prognosis, of course, is governed by the number and the size of the tumor load, but it's also driven by some biological alterations. And these can be summarized here with the 4 genes that you can remember: TP53, APC, RAS, and SMAD4. And you can see on this work from the MD Anderson, it's possible to grade a patient and to stratify the risk of and the prognosis according to the number of mutations observed in tumors. Another major advance comes from the immune checkpoint inhibitor in the very particular subgroup of patients who express a microsatellite instability. You can see that these patients are excellent responders to immune checkpoint inhibitors. And this is important that even in some patients who are BRAF mutated patients with a microsatellite instability, they also observed a very good result compared to chemo alone in this study. And the new question now, we are going to see more and more patients with microsatellite instability that will express a major response to immune checkpoint inhibitor. Should we resect residual disease, yes or no? And one part of the response is coming from this study. You can see 120 MSI patients treated by immunotherapy, 14 underwent surgery, and 12 were found to have a complete pathological response, so no more residual tumor cells on the pathology, despite residual tumor, or the impression of residual tumor on imaging. So the conclusion even if we need to be careful, is that so far in responders, there is no more role for local treatment, but this should be maybe discussed in patients with a dissociated response or unresponsive to immune checkpoint inhibitor. So another part is to speak about oncological surgical strategies. And this is important because in this recent paper, you can see they ask 10 cases of patients with colorectal liver met, some simple to complex cases. They make a survey among 43 expert liver surgeons from 22 countries. They ask them, what would you do? Open, invasive, portal vein, one stage. And you can see that experts do not agree. When it's a very low complex, for simple case, you can see the kappa index is almost 0 here, meaning that experts totally disagree whether we should do open or minimally invasive. Of course, when it's very complicated cases, there is most of them agrees. But if we, for example, if in complex cases, you can see if we can do a type of surgery in one stage or two stage, you can see that there is a total disagreement. So it's very interesting to see that finally, even experts do not agree. And this is important to keep that in mind, that because in this talk, maybe, and for sure, you may not agree with my point of view. So I think a few relevant questions should be answered in a patient with colorectal liver met, whether it is resectable or not. Synchronous, metachronous, are there any extrahepatic disease? Do we have, is it from a colon or low mid-rectum? And are there any symptoms related to primary tumor? So to define resectability, 2 points for me seems to be important. MRI is doing much better than CT for detecting small lesions. So I think in 2022, it is no more possible to consider liver resection without MRI. And the other point is that we should discuss the resectability with numbers and with volumetric, precise, accurate volumetric assessment of the future remnant liver. And this should be done by a liver surgeon and not by oncologist. I have a lot of respect for medical oncologists, but sometimes they give their point of view. This patient is not resectable, it's impossible. And sometimes they may be wrong. So it's important that resectability should be defined by a liver surgeon and not by oncologist alone, based on volumetry and MRI, of course. And finally, we should be pragmatic rather than dogmatic. For example, we should not say 10 lesions, I never operate in a patient with more than 10 or things like this. So a very common situation, a patient with synchronous and initially unresectable disease. I think there is no many question. The objective is to start chemo as soon as possible with the objective to induce a shrinkage of the lesion and to make it possible to do rescue surgery. And this is very important because initial response to chemotherapy is correlates with the chance of making this rescue surgery, this secondary resection. So this as a consequence, we may start by a very strong induction chemotherapy for this patient with the objective to induce a major response and to make it possible to do a secondary resection. So 3 is better than 2. This was shown in this phase 2 trial, showing that when you make a triplet chemotherapy, here FOLFOXIRI versus FOLFOX alone plus BEVA, you increase your response rate and you increase the chance of secondary resection. The same, if it's possible, if you have a KRAS wild type patient, anti-EGFR therapy also increase the chance of secondary resection. This was shown in this trial from China with a liver only KRAS wild type patient. You can see when you add cetuximab, when you add anti-EGFR therapy, you increase the chance of secondary resection from 7% to 25%. Things are not so clear when you use anti-VEGF, bevacizumab, for example, because, you know, as you can see here, bevacizumab is inducing not a shrinkage, but like a liquefaction of the tumor. The tumor is becoming a bit like a cyst, but the size is not really changing. So it is not sure that you can expect such higher resectability with anti-VEGF. So it is worthy to fight because you see that when you have a patient with initially unresectable disease, that you succeed with chemotherapy to achieve resection, finally the prognosis becomes quite similar to that of patient with upfront resectable disease. So it is worthy to fight. So what to do with primary tumor? This is also a very important point. We often have patients with bleeding. Actually, bleeding is not a big problem because it will disappear with chemo. After 2 or 3 cycles, usually bleeding is going to stop. Of course, things are totally different if you have a perforation, because in that case, it is absolutely not possible to do chemotherapy in a septic patient. So you have to treat the primary tumor. Keeping in mind that digestive anastomosis at that time may be at risk, and if there is a fistula or a peritonitis after anastomosis, this patient will stay in ICU longer, be reoperated, and you will lose time, and you will induce a big delay to chemotherapy. So be careful with digestive anastomosis at that time. Obstruction, of course, it is not possible to do chemotherapy in a patient with a colonic obstruction. Our position is to propose a stoma if left-sided tumor, or resection if right-sided, with or without anastomosis according to local condition. But the main message here is to avoid any delay to start chemotherapy. In asymptomatic patient with unresectable liver disease, should we resect the primary tumor? 2 trials last years, one from Japan, which says that same result, same survival, and the Kero trial from Netherlands, we observed higher 60-day mortality in the group of upfront surgery. 11% of 60-day mortality in the arm surgery first versus only 3% in the chemo arm. So the message here is to say that there is no place for in asymptomatic patient with unresectable liver disease, no place for upfront colectomy. The objective is to start by chemotherapy and then to see. But doing the colectomy or treating the primary will not improve in any way the prognosis, but will increase the risk of delaying chemotherapy. Recent update about a reverse strategy. Reverse strategy is starting by the liver and then treating in a second operation the primary tumor. You can see from this study from the Liver Met Survey Registry, 500 liver first strategy, more often if colorectal cancer. You can see that if there is a single lesion, no difference, liver first versus primary first. But if there is extended liver disease, liver first strategy is doing better. So we can keep that in mind, that maybe for patients with extended liver disease, liver first should be preferred. You can see this is the same here. Finally, in a patient initially unresectable, asymptomatic, so we would do chemo, then liver first, then chemo, then treating the primary. And in this other case, large T4 rectal cancer plus 2 small lesions in the liver, maybe it would be more advisable to start by the surgery of the rectum. But the main philosophy is to start by the location with the highest risk, and also to combine hepatectomy and resection of the primary, colectomy or proctectomy. This combination at the same operation should be avoided if you have to do a major hepatectomy. One word about low and mid rectal cancer, because this year has been published this trial in the Lancet Oncology in FOLFIRINOX followed by radiochemotherapy versus radiochemotherapy first in locally advanced rectal cancer. And you can see that in the arm neoadjuvant chemotherapy group, so first FOLFIRINOX, then radiochemotherapy, results in terms of disease-free survival and overall survival were in favor of starting by FOLFIRINOX. So FOLFIRINOX first is becoming now in France, since this trial, the new standard for locally advanced rectal cancer, meaning that we can apply the same reasoning for rectal cancer, low or mid, with synchronous colorectal lesion. Synchronous and upfront resectable. This question was addressed to a panel of experts, and most of experts were in favor of starting by chemotherapy first, even if patients are upfront resectable. If you look at all the guidelines from Japan, USA, Europe, all say that surgery should be associated with chemotherapy. But actually, if you look in the real life, you can see that upfront resectable is actually an heterogeneous clinical entity. Meaning that it's important to discuss on a case-by-case basis. If you see, for example, a single metachronous small lesion, apparently, according to this study from the Liver Met survey, no really need for preoperative chemotherapy, but things are different maybe in patients with a much more advanced disease. One word also about metachronous lesion in a patient previously treated by FOLFOX. Patient have a colectomy, adjuvant FOLFOX, and then, for example, 2 years or 1 year later, there is a colorectal lesion. And actually, this subgroup of patients already treated by adjuvant FOLFOX should be considered as a risky patient, because the tumor that will appear contains some tumor clones, which are resistant to oxaliplatin. So it is already developing a liver met when you already have been treated by FOLFOX. We can expect aggressive tumor biology, and this is a subgroup of patients at risk. So the message here is to say that in a patient with upfront resectable disease, should we given chemotherapy before or after? No absolute evidence for neoadjuvant for everyone, but maybe we can do upfront resection for a single lesion, small lesion, late metachronous, when hepatectomy is easy with a very low risk of morbidity. But in contrast, in patients with multiple tumor, large, synchronous, or which require a major hepatectomy at high risk of morbidity, and morbidity meaning a delay in adjuvant chemotherapy, starting by chemo first should be highly advisable. I will challenge now some old concept. The first is the R0 at any price. In some patients, you want to keep intact a major vascular structure, such here in this case the middle hepatic vein. You don't want to sacrifice such a structure, and you can be forced, or you can have no other choice than doing a resection with R1 by necessity, meaning that you're going to detach the tumor from this major vessel. And this R1 by necessity has been assessed by our group, and showing that in a patient with an important number of lesion, R1, when it was done by necessity, yield similar overall survival and disease-free survival compared to other patients. So R1 by necessity may be possible. So we also learned 20 years ago that no surgery if progression while on chemo. Maybe things are not so black and white now, with more recent data showing that in selected patients, even progressing while on chemo, maybe surgery should not be absolutely contraindicated, provided that no more than 3 lesions, no big tumors, and no CEA more than 300. You can see that when none of these adverse factors are present, we can achieve some interesting and reasonable survivals, even in a context of a progressing disease. We also learned in the already old paper that vanishing lesion on CT after chemo does not mean cure. In this paper from the group of Bernard Norlinger, you can see that when a lesion disappears on CT, there is still remaining microscopic disease in 80% of cases. Actually, this is no more exactly true if we use MRI with a specific contrast agent. And you can see here in this paper that when there is a disappearance of a lesion, when on an MRI using specific contrast agent, finally the predictive positive value of MRI was relatively high, so a much more reliable tool to predict the effective disappearance of the tumor. So the message here is to say that if we really want now to update or to have an accurate idea of missing or vanishing lesion, we should use MRI with a specific contrast agent. It's much better, of course, than a CT scan alone. So does adjuvant chemotherapy improve the prognosis? This was done in a Japanese randomized trial. You can see last year. You can see that when you propose FOLFOX after an hepatectomy, the disease-free survival, you improve your disease-free survival, but no difference in terms of overall survival. There was no subgroup identified, and this means that when a patient will recur, they will be treated by chemotherapy, and at the end, the prognosis become similar. So the improvement in terms of disease-free survival does not translate in terms of overall survival, and this is for me the clear indication that there is a finite a number of chemotherapies that a patient can support. Beyond a certain number of cycle, the patient cannot support any. The condition is patient are no more suitable for chemotherapy. So we have a limited number of chemotherapy cycle that the patient can support. And this is the reason why you will find this editorial showing that maybe perioperative chemotherapy should be much more carefully discussed, because as you can see, as you have seen in the previous trial, no link between disease-free survival and overall survival. And we should maybe be sparing chemotherapy. Given the neurotoxicity, there is a maximal dose of oxaliplatin that a patient can afford, and beyond which it's no more possible to give chemotherapy. So the idea, the philosophy here is to say we should keep chemotherapy when it is really necessary. I will skip that. One word about the surgical technique. So 4 years ago, has been published the Oslo Comet randomized trial, which compare in patients with a median number of 1.5 lesions, so very limited liver disease. They compare open approach to laparoscopic approach, and you can see that lower morbidity in the laparoscopic group with same quality of resection. So very encouraging result in favor of laparoscopic approach. But we should keep in mind that this is true only for patients with a very limited disease. A median number of lesions in this trial, 1.5. Another point is that laparoscopic approach is associated with survival improvement, according to this meta-analysis. And you can see some reason advanced to explain such superiorities: higher chance for adjuvant chemotherapy, lower morbidity, lower immunodepression related to surgery, and maybe the fact that patients who have been operated by laparoscopic were operated by surgeon with larger experience. One word about pushing the boundaries of resectability, and we now have since 2 years the long-term oncological results after ALPS for colorectal liver mets. These data are coming from the ALPS registry. 22 centers, 468 patients resected, with almost 5% of 90-day mortality, so quite significant mortality. And you can see that poor results were observed in patients operated while on progression, as we have seen previously, in patient with KO and RAS mutation, and in patient with primary tumor located in the right colon, likely due to biological differences in terms of aggressiveness. I have to say also one word about the LIGRO trial, which is the first randomized control trial from Sweden that compare ALPS versus a classical two-stage hepatectomy. You can see in this trial that the 90-day mortality was high, even higher than in the registry, 8% in the group of ALPS, and also high even in the classical two-stage, 6%. And they recently published their long-term result, showing that ALPS at the end was doing better, but of course with so sorry, there is a slight mistake. It is not failure of the strategy. It's not 92%, but 8% in the ALPS group versus 20% of failure strategy in the classical two-stage. And you can see median survival in the two-stage 26 months versus 46 months. So everybody has been a bit surprised by such a poor result in the two-stage classical approach compared to ALPS. So I think this result and the superiority of ARBS still should be clearly demonstrated. It's important also to consider maybe a very attractive alternative to ARBS, which is percutaneous preoperative portal vein embolization combined to hepatic vein embolization. It's possible to make embolization of portal vein and to put a plug in the right hepatic vein and in the middle hepatic vein. And if you do that, this was done in this study, in multicentric study, 39 B embolization versus 160 portal vein embolization. You can see that you increase the percentage of hypertrophy, 59% versus 48% in the portal vein embolization alone group. So maybe this venous deprivation may be a very interesting strategy in patients with a small left lobe without lesion and most of the liver disease in the right liver or in the segment 4. So maybe potentially a very promising and interesting strategy, probably less morbid than the ARBS. So recurrence is part of the game. It's important to keep in mind that even despite all our efforts, most of patients will relapse. And the idea is to remain curative as long as possible. We know that patients who can undergo a second hepatectomy, even a third hepatectomy, they are doing much better. And this is why we always pay attention to the feasibility of a repeat hepatectomy. And this comes to the concept of preserving liver parenchyma, meaning that if you have, for example, a patient with deep lesion in the right liver, if you do a right hepatectomy, patient will recur. Maybe if they recur in the middle of the left liver, it will be much more difficult to treat such a recurrence rather than in a patient who still have a part of the right liver that you will be able to keep, and then you will be able to treat the left liver. And so such a preserving liver parenchyma was associated at the time of the recurrence to a much better outcome compared to patients who were operated by upfront major hepatectomy. So you can see that in this patient with two small deep lesions in the right liver, should I do a preserving liver parenchyma or a right hepatectomy? Actually, if you do a preserving sparing parenchyma approach, you have a much higher chance to be able to perform a repeat hepatectomy when the patient will relapse. And this comes to the concept of trying to do our best to increase the time to surgical failure, time to keep the patient able to sustain a second, third, fourth hepatectomy. I am close to the end of this talk. Just a word about, to conclude, a word about the place of liver transplantation. You know that now we have some drugs that combines anti-tumoral effect and immunosuppressive effect. We have modern chemotherapy, very efficient with high rate of response, and we are able to better detect extrahepatic disease. So these three points made it possible to reconsider liver transplantation, which was considered in the past as an absolute contraindication for patients with colorectal liver met. And the major contribution comes from Norway. You know that Norway is a very particular country in that in addition to the fact that it's if you want to buy Coca-Cola you will pay a glass of Coca-Cola 15 euros. They also have some graft organ in excess, and they could develop a program of liver transplantation for liver-only patients with very strict selection criteria, no extrahepatic disease, primary tumor was resected, patients are stable or responder under chemo, and when they apply such selection criteria, you can see that they have very good result or very encouraging result on terms of overall survival, so which is a very important point when you consider liver transplantation. But you have to expect a very high rate of relapse, because as you can see, the disease-free survival was almost 1 year, the median disease-free survival almost 1 year, but it seemed very interesting to see that this patient will relapse, but most of them will be treated again, either by pulmonary resection, radiotherapy, lymph node resection, and all this second treatment or further treatment explain why it's possible to transform such a poor disease-free survival into an excellent overall survival. They report 2 years ago more recent result in terms of transplantation, and you can see that with more mature result, finally in the best scenario, so patients with left-sided colon cancer transplanted, we can expect 60% survival at 5 years after transplantation in, once again, very selected patient. So we are waiting now for the Transmet result. Transmet is a multicentric French European study, actually, with Belgium also. The PI is René Adam from the Paul Brousse Hospital, which compare chemo plus transplantation versus chemo alone for non-resectable cancer. I think in the next months we may have the result of this trial. So my conclusion is to say that colorectal cancer is an heterogeneous disease. Wrong prognosis and therapy are now directly influenced by molecular biology. Chemotherapy, for me, is an emergency in synchronous patient. Laparoscopy is a new standard in patients with limited disease. Parenchyma sparing policy should be encouraged. And be careful with excessive use of ARBs and liver transplantation. So just to say also that even the best surgeon will need an excellent oncologist, and this is very important to discuss every cases with other specialty to define together the best management. Thank you very much.
Thank you. Outstanding presentation as expected. So now we are gonna open it up for Dr. ENNE and Dr. Araújo to discuss it up and make all the questions and the points that they think are indicated. So it's open for you.
Okay, Marc, you gave us an amazing lecture, one of the best I saw. Congratulations. I learned a lot. So you are in the mecca of the liver surgery, yes? You worked at the Paul Brousse Hospital, who pushed the limits always, always, always. René Adam is the father of two-stage hepatectomy, and maybe will be the father of the liver transplantation for liver mets in Europe. But I would like to ask you one point that you didn't talk about. We are seeing more and more patients with 10 or more lesions, bilobar lesions, involving all the segments of the liver. But liver transplantation is not too close for these patients. I want to ask you if there's a place for debulking surgery for those patients, And of course, after a good chemo response, and how much do you need to resect in those debulking surgery? Looks like the same for net tumors, 90%, 8%. What should we do? Is there a place for debulking surgery, and how much do you resect? Thank you again.
Thank you very much for your kind words. And this question, which is a very, very, very important question. Just before I think speaking about cyto reduction, indeed I didn't speak in this patient with initially a full liver full of small lesions, which are very, very problematic patient. My feeling is that of course, chemotherapy is very important, but there is sometimes a fantastic tool which is a bit complicated to use. This is intra-arterial chemotherapy, which is quite used a lot in New York, but we also use it here in France with a different regimen. We use intra-arterial oxaliplatin, and we have observed some huge response. So it can be very interesting in this patient with a huge involvement of the liver. And then in excellent responder, of course, this will induce the disappearing of many lesions. Many lesions will disappear. And we started like a program. Now we have done about 25 patients in super responder, meaning that many lesions will disappear. We will only try to resect all the macroscopically residual tumors. And we have the feeling, of course, these are very selected patients because they are super responder to chemo, but we have the feeling that we observed good results so far, but we lack of long-term follow-up. So we didn't so far operate patient and letting macroscopic tumor like we could do in neuroendocrine tumor. The idea is major responder. We remove all the residual macroscopically visible lesion, and we pray, I would say, so that disappearing lesion will not reappear. Or if they reappear 6 months later, we will try to reoperate, doing again a rehepatectomy. And maybe my question now, I think the next question is whether such a strategy is similar, for example, to liver transplantation. Maybe it's will become in competition with liver transplantation.
Yes, because it's not all the patients that have a liver to replace, to become transplanted. So we are dealing more and more with those kind of patients.
Yes. Absolutely.
Thank you, Marc. Rafa?
So thank you so much for this outstanding lecture. I guess that you could approach many issues that are really the real players of this field of that you are dealing today. But my point, I was wondering, in the practical view, how do you select patient to decide your approach for resectable colorectal liver metastasis? Because, you know, when, according to the paucity of the evidence in the literature, especially in the prospective and randomized data, there is no clear consensus. So sometimes use some series from here or there, national or international database. But my point is, when you look for a patient, what's the threshold that you check, and how do you select patient for the first surgery first or chemotherapy first? For a resectable, for example, metachronic, but multinodular colorectal liver metastasis. What make your decide, you know, go in one direction or another? Thank you.
Thank you very much for this question. In practice, in synchronous patient, in the group, in my group, the philosophy is to start by chemo. Even if it's we just discovered a patient recently, right colon cancer, asymptomatic, with 2 small lesions in the right liver. We decide to start by chemo because we want to cool down the fire, to crush the fire, because we feel that, of course, even if technically it can be operated, if there is a complication, there is a delay, maybe there is some small lesion that we cannot see, and it will reappear as we cannot doing chemotherapy. And so the idea is to start synchronous patient, even limited disease, we start by some chemotherapy, and maybe 4 cycles is enough. In metachronous patient, it's a very difficult question, because in metachronous patient already treated by oxaliplatin after the colectomy, for example, they already received 6 months of FOLFOX. Most of them, they have neurotoxicity, so it is difficult to give them again FOLFOX. So if the lesion is small and single, we can go for upfront resection, especially when if it's easy, you are sure that you will be at 0. But if it's larger lesion, close to major vessels and everything, we discuss, and usually we give irinotecan, and then we propose surgery. This is a bit our philosophy. And also, after surgery, we propose 3 months of chemo to the patient.
So do you are considering just the resecability or the tumor burden? For example, if we have like 5 lesions in the left, hemi-left liver, so you can do a straight left hepatectomy, that's fine, that the complication is low, but like 7 lesions, big lesions, that's the difficulty of select patients. That's why, as you showed in your last topo, your last slide, that we have to have a multidisciplinary decision exactly to discuss. But I mean, it's hard because I used to train in Brousse, and Brousse it's a place where people are always pushing the boundaries of liver surgery, and then it's amazing how it works and how you can teach people. It's amazing. But I want to understand and see a clear idea about that, and it's difficult, at least in my reality. But I'm trying to check to have some practical threshold. Go there. At 5 lesions, I do it. 7 lesions, not. So
no.
I don't think.
If the patient is resectable in terms of volume after a good MRI, to be sure that we detect everything, and this is even more important if you do laparoscopic, because laparoscopic exploration by lap with ultrasound is not so easy than with open. But after a good MRI and a good volumetry, if the patient is resectable, whatever the number of lesions, our policy is to propose even resection. So we don't care in terms of number or size. It's not we don't. There is no limits. Of course we can expect high risk of relapse, and this point is very important, that we explain to the patient, a patient with several lesions. We explain, okay, we're doing a right hepatectomy or extended right, but maybe there is a high risk of relapse. So we can discuss even adjuvant chemotherapy with adjuvant intraarterial catheter, to do oxaliplatin, adjuvant oxaliplatin. So you decrease the risk of relapse. We explain also to the patient that maybe if he relapses, we will have to come back again to surgery. But there is no clear limit in terms of number, provided that MRI is okay and the volume also is okay. Another point that I didn't discuss also is that I think what is absolutely catastrophic in the story of this patient is that when there is a big complication, they underwent a liver resection and they were doing the liver insufficiency after major hepatectomy. It is terrible because even if they survive 3 months later to liver insufficiency, they will never be able to receive again chemo. You will see the patient with ascites 3 or 6 months later and already a recurrence, and this is the end. So I think it's very important to be very careful in terms of resection, not to be really super aggressive. It's a bit different that in, for example, for cholangiocarcinoma, which is another story. I think we have to be more careful even in this patient, and also to be careful with this patient who has been treated with a lot of chemotherapy, with the toxic liver, this blue liver, with a sinusoidal SOS syndrome. It's important to check the platelets before the ICG clearance, to be really sure that this liver is able to undergo a major hepatectomy.
Thank you so much.
Yeah, I have one question from Marcelo Bruno. I think that one part of his question you have already responded. It's about where the very high-risk patients with plenty of metastases. You also said in your presentation that the role of adjuvant therapy sometimes is questionable when you think about liver only. But he said in very high-risk patients, if you think that the adjuvant therapy in this scenario, this setting, the use of intraarterial chemotherapy in these patients would play a role in the long term?
There's been a randomized trial in France in this patient at risk of relapse. They have been, after hepatectomy, they have been randomized adjuvant systemic versus intraarterial systemic intraarterial chemotherapy. We may also have in the next year the result of this trial, but I don't know if this benefit in terms of disease-free survival will be translated in terms of overall survival, because it's always a big problem. Honestly, I don't know, but we have seen a few patients with fantastic response after intraarterial chemotherapy, with really complete pathological response. So the problem of arterial chemotherapy is a logistical and technical problem, because it's always radiology. You have to have a good radiological team, people, oncologists, the nurse, everybody should be used to the technology, arterial anatomy, some variation in arterial anatomy. So it's always a bit complicated, but I think it is worthy. This is my point of view, but it remains to be clearly demonstrated.
Sorry, thank you, Marcelo.
My last question is about minimally invasive surgery. How many patients, or which percentage of patients with liver mets can we offer minimally invasive surgery? Meaning, how much number of bilateral liver mets or location? What do you think?
This is very, very important question also. For me, laparoscopy and colorectal liver met, to provide similar results than open, It's important to have a very good preoperative imaging, because you cannot touch the liver, you cannot explore like the same way than in open. So you have to, MRI is absolutely mandatory, good MRI, and to have a very clear idea of what you're going to do by lap. I think it's very difficult to make improvisation when you decide to do laparoscopic liver resection. You have to come to operating room with a very clear plan of what you're going to do. In terms of number, the problem is that sometimes to resect a deep lesion, you're going to spend a lot of time by laparoscopy doing several clamping, and then if you have to treat another one and then another one, sometimes at the end, to treat 3 lesions, you're going to spend 6 hours. In open, it's done in 3 hours. So and with less clamping. So in liver, which has suffered, I think it's honestly a case-by-case balance between the duration of surgery. It's not so easy to do sparing parenchyma strategy by laparoscopy, especially for deep lesion. Now there is also a device which is very helpful to do radiofrequency ablation with ultrasound probe, with a guidance, with a laser that you can use sometime to treat some deep lesion. It's difficult question, case-by-case discussion, I would say.
Thank you, Marc. Thank you.
Rafael?
Well, this point, it's really interesting about the minimally invasive, and we think that it's pretty clear, and I really appreciated the way that you showed us that it should be pursued in cases that are more congruent with the randomized clinical trial. So it means restricted disease, standard resections. It's so that you have evidence for that, and for sure we can improve it, but not in randomized trial fashion. And this is really interesting. And one thing that I was wondering was about the R1 resection that you showed us. This series, it's impressive, and it's a series really important. But in the practice, we are talking about the vein margins, and so we assuming that they are really important, and for sure you keep that segment, and that's why we are pushing to preserve them and doing this technique. But in the practice, we are using and considering to keep it close to the pedicle as well. I'm asking because in the pedicle, you still can go fascially, go by close to the fascia and removing, doing like for tertiary branches, whatever we're trying to do it. I'd like to listen your opinion about that.
Thank you very much. This is a very difficult question. The R1, the message of R1 is only by necessity.
Yeah.
So I think it's important to underline this point. R1 is not the first option, is really the last option when there are no other option. You have to preserve this vascular structure. There is no other choice. Then R1 can be justified. There is no absolute rule, but it is possible in some case to get a detachment and to preserve vascular structure when there is no major contact, a small contact in a small surface of tumor. It's possible to make and to preserve the vascular structure. And I think this can be done on hepatic vein. This can be done on the vena cava. It's rare. I don't know in your experience, but it's rare that a lesion close to vena cava really invades the vena cava. This is not the same than in intrahepatic cholangiocarcinoma, or there is a huge retraction with invasion of vascular structure. It's a bit different, especially in tumor already treated by chemotherapy, which has responded to chemotherapy. I think it's possible. There is no involvement. I think it is much more difficult in tumor close to the confluence, biliary confluence. It is sometimes a bit. We have seen some local relapse at that location, so it's important to be very careful at this part. But the message is to say that it's really only by necessity. In patient responsive to chemo, it is possible, knowing that for hilar lesion, so Gleasonian pedicle, sometimes be careful. Be careful, especially when there is 180 degrees contact. This is, if I can say so.
Thank you. Nice thoughts. Thank you, man.
Just another question. What's the experience of the center on robotic surgery? Are you already starting on robotic as well, or?
Yes, we have started, but there is a bias. We have started, but not for colorectal liver met. There is a bias in that we have quite a significant number with a great number of lesions that are not really good candidates, we think, for laparoscopic surgery. So we keep laparoscopic surgery in a few cases with a single nodule sometimes, even for hepatectomy. I didn't speak that, but it is possible to do hepatectomy, as you know, by laparoscopy. But we keep robotic approach more for pancreas resection or for anatomical resection, left hepatectomy. So far for HCC or benign tumor. But the indication in terms of colorectal liver met in our center, not so many. Maybe because of a bias of recruitment.
Okay, thank you. Marcelo, Rafael, final questions?
No, I don't have final question. I just want to say thank you again, Marc. It's a night in Paris, very cold. You are starting the winter in Paris, so you are in the time to go to the bed. Thank you, Marc.
Thank you very much. Thank you very much, Marcelo. Thank you very much.
Me neither. I don't have more questions, but I really appreciated this opportunity because it was a great talk, an interesting discussion, because, you know, many things are showing up, but we still have a lot of controversies, and
Absolutely.
you know, that's why we are here and trying to pushing it far further. And we appreciated the way that you present and showed it for us. And thank you so much, Marc. I really appreciate it. And also thank you, João, for this opportunity. It's amazing. Thank you, Marcelo, as well. It's really good to stay with you here.
Thank you, Rafa and João also. Thank you.
I would like to thank you all, and I would like to thank you, Marcelo, Rafael, and special thanks to Marc-Antoine Allard for votre présentation. If you excuse me, if I can speak French, I feel more comfortable. So, je vous rends en hommage, je parle en français aussi, même au centre de HPB du pôle Brousse. Vraiment quelque chose d'unique au monde et dont viennent toutes les nouveautés. Et donc, je vous remercie énormément. Et félicitations dans tous les services, que ça fait plus de 20 ans que je suis passé, et voilà, et c'est toujours, comme elle a dit, Raphaël, en poussant les limites, et ça, vraiment, c'est quelque chose qui fait des effets partout au monde, parce qu'il y a toujours des papiers qui viennent pour le Brousse, qui sont discutés, l'expérience, des gens qui sont y passés et qui font la HPB partout dans le monde entier, que ce soit le Brésil, que ce soit en Asie, un peu partout, quoi. Hier, j'étais à Rio, j'avais connu un gars de l'Inde qui fait 300 transplantations d'honneurs vivants en Inde. Prachon, je ne sais pas si...
Ah, Prachon de Bangui, oui.
Oui.
Ouais,
Et
Prachon de
donc,
Bangui.
j'étais impressionné. Donc, c'est vraiment, pour le Brousse, un peu partout. Ce sont vraiment 300 transplantations qu'il faut ajouter à l'expérience pour le Brousse parce qu'il a pris là-bas. De même, tout ce que Raphaël, Marcel, moi-même, j'ai fait en cette l'école française de chirurgie. Donc, merci beaucoup. Désolé pour l'air. C'est
Non,
presque
non,
une émission.
merci. C'est moi qui vous remercie. C'était très agréable de pouvoir échanger avec vous. Et c'était un honneur de pouvoir représenter mon hôpital et le groupe et toute l'équipe. Écoutez, vraiment, je suis très heureux de ce moment. Muito obrigado, muitíssimo obrigado. E bom final do dia para vocês. E até me liga quando passar em Paris. Seria com prazer. Tá?
Ça va être bientôt, vers le 26. Donc,
Ok.
merci, bonne nuit.
Merci
Merci à
beaucoup.
tous.
Merci,
À tous et
bonne
toutes.
nuit.
Merci à
Allez,
vous.
au revoir.
Au revoir. Merci.
Bonne nuit.